Thank you, Cha and AeHIN, for having me tonight. I'm connecting from my house, so I apologize if my connection would rather be spotty. I normally do this from the office, but since it's already late in the evening or relatively late in the evening, I'm connecting from home. I'm especially appreciative of you coming out tonight online in a way for sharing with me some discussions or having some discussions on normative considerations in ethics. So as Cha mentioned, I'm a project leader of a group trying to develop ethics guidelines on COVID-19 hospitalization crisis level. And we did this a month soon after the lockdown in the Philippines, right? So a quick disclaimer: I do not, my discussions will not be the official discussion of the group. We only have the guidelines as the base agreement, so to speak. After that, we are on our own rather. And special thanks to my colleague, Dr. Lenny Fernandez, for her slides. Some of the slides, anyway, I'm using in this presentation. All right, so we begin with a vignette on who gets the resuscitator. I hope you can get this clearly. I'm starting it now. All right, I hope you got the dramatization by TVUP. I apologize for our international colleagues if we haven't done an all English version. In any case, just a quick summary: you have 3 admissions, 3 cases with 1 minute difference, 1 minute apart. The first patient A involved 75 years old, post arrest. He had cardiac arrest, and then he's negative. But then the patients would, his family would have him revived. Patient B, she's 85 years old. Only a minute after patient B, patient A, not enough time to set up. She is rather, she has COVID pneumonia and is on high flow nasal cannula, and her family is also very aggressive, wanting her revived. The third case, patient C, is 35 years old. He's also COVID positive and has COVID pneumonia. He's critical, but he has an advance directive. Quite strange for, not unusual, not so usual for a 35 years old having an advance directive. But his wife wants the directive overridden. So I want you to please participate in a poll. Please choose which one you'd prefer to get the last ventilator. Right? Quickly, the others, please. We have 14 participants. If you see your poll, please. All right. So, interesting. Okay, so maybe we'll just wait for a 50% turnout in the poll. Maybe 50% plus 1. That's a democracy, maybe already, or plurality. We'll go for plurality. Okay, so we only have a few of you guys voting. I hope the choices are clear to you. Patient A, 75 years old male. Patient B, 85 years old female. And patient C, 35 years old male. All right, so maybe you're having a hard time. So the plurality has it, that patient C would be the one to be saved, or to be given the last ventilator. All right, so that's it for now. And then please note of your choices later. I will share the results for you and see if you may have a change of heart later on. All right. Okay. So moving on. So why is there only one ventilator? As you can see, that only happens, or at least likely to happen, when you have a crisis situation where there's just too much demand. There is a surge, major surge after major surge, that the capacity of hospitals has been overwhelmed. The hospital has been overwhelmed, and there is just 200%. No, and in terms of qualitative characteristics, you have insufficient staff. In most parts, I mean, many parts of the country, that would be normal, but this is way too abnormal, even for lack of resources, especially medical staff. Supplies lacking, allocation of we'll have to decide on allocation of life-saving resources, and the standard of care is no longer usual, no? And that is really the premise of this talk when you have a crisis level situation. And epidemiologists would imagine mass casualty scenarios. So you're talking about in India, for instance, or Italy in the early COVID crisis. So in the Philippines, so there's been a work of Dr. Habana counting the ventilators in the country, about over 1,000. And for conventional use, you only have about 314 being activated. But on a contingency, you'll have full use, all use of all the ventilators available. But then in a crisis situation, you need double, right? Now, systems would be responding to scarce resources, obviously. And it depends on your hospital where you are. In some hospitals, they're able to stockpile. They're able to activate a network. In Metro Manila, we have, there was a suggestion, and there was somehow to some extent followed, of suggestion of having a hospital network, no, triaging the different COVID cases, as opposed to just people going to individual hospitals. No, then you have to mitigate all these several measures, of course, social distancing and so on. There's going to be a command center. Early on, we were able to, the country was able to respond to this, but somehow it wasn't sustained, or not sustained well. And there's going to be redistribution of scarce resources, activation of alternate care. Some regions had to fend for themselves, essentially. One LGU, for instance, resorted to some traditional medicine. And of course, monitoring of resources. And maybe most relevant to our discussion tonight would be the triaging system. And I will detail that system in a bit. No? So why talk about ventilator? No, there are, of course, many other things to talk about in terms of scarce resources, but ventilator is a very good proxy for scarce resources, because it's a life-saving binary resource. Either you have it or you don't. No. And time to save life will be very limited. The patient dies in a few minutes if it fails to start, for instance. That's why ventilators would need FDA approval. No, it has to be very reliable, or if it is removed. No, so this consideration. So ventilator is a good proxy for scarce resources. So our study group started about a month. We came up with these guidelines, and I think you have the link, and you have seen, some of you have seen the guidelines already, and I hope you take a closer look at this. So we're quite a team. I am proud of the team, and we made the guidelines. So it's quite a range that we covered. We covered 11 sections. We have 11 sections, 30 guidelines in all, from principles, admission triage. And tonight I'll only be limited with ICU allocation, but there are other considerations like research and even post-mortem care. What do you do when the patient dies? So there's the link below. I hope you take a look at that link and ask questions later. So I have another poll. So given the situation we have just shown you, who's going to decide? All right. So earlier, we only have a few of you participating, less than 50%. I hope this time more will be participating, and will have more certainty or certitude when they think about these issues. So who makes the final decision in prioritizing use of a life-saving intervention, say a ventilator? Our number one, the patient, family, physician in charge, or hospital director. Okay, so we have 41% of the 15, so less than 7, less than 8. All right. Oh, good. We have better participation this time. So you're resting the burden on the physician in charge. All right. So remember your choices, and we'll see if this presentation is able to change your mind. So give us feedback later on. So all right, that's it. I will share the results with you. All right. So you see your choices. That is a typical audience response on the question. All right. Okay. So why clinical criteria might not be enough, no? In a crisis situation, a very important contextual feature of our discussion tonight. You have all sorts of constraints that are not normally present in non-crisis situations. So you have shortage of emergency and critical care, rapid change in numbers of patients, no? You have surges, you have a terrible way of getting accurate information, no? In some regions in the Philippines. I'll just give you an example. Testing results testing have not been well documented, and in some regions there are problems with their information systems, no? So variability of specific scarce resources, no? And then all this would be factored into your aim or your goal of coming up with effective, equitable decision making. On the other hand, you would want to have these goals, no, as general rule, no. You want to prioritize, because it's no longer a matter of saving everyone, but it's just a matter of saving as many lives as possible. So you are left with certain things to consider. One would be technical, and I'll explain to you momentarily what that means, no? But mostly clinical decisions anyway, that as I will show you later on, would not be discriminant, would not be enough to screen out, because in the case of ventilator, you only have one, but then in one of the largest hospitals anyway, there are 100 people waiting for that ventilator, and so they die just waiting, no? And there could be multiple conflicting ethical values, not so much surface, no, because of the crisis, and people would just be doing ad hoc decisions. So it's a terrible outcome, no, not to talk about these conflicting ethical values. The contextual issues are also value laden, and so if you pick one, even on technical grounds, you may not, or at least the decision makers may not be aware of the deeply ethical choices they have made, no, despite not being consciously articulating them, no. And the situation is rather fluid, no. So what are the norms for consideration, no? So we have time, or those time related anyway. Clinicians in the audience might be thinking about prognosis, and of course in the crisis situation there is preponderance of medical futility. There's so much we don't know about COVID. It's good when you have a mild case, but if you have an advanced case, a critical case, in many areas in the country, in a way, you're pretty much done, no? And then another consideration is, of course, patient autonomy. We want our patients to decide for themselves. Fair inning arguments. This may be favoring the younger generation, because you would want them to flourish or to reach a certain ripe age. But that is one of the considerations we have. And then finally, I will talk about fair process as opposed to fair outcomes, now, which cannot be guaranteed in a crisis situation. Now, in relation to time, as you know, the non-crisis or pre-crisis hospitalization would always be about first come first serve anyway. At least what people would profess, or the medical profession would profess, that if you come in first, we'll treat you first, we'll serve you first. And in a non-crisis situation, all available means should be used. But that's no longer possible in a crisis situation. As a matter of fact, if you look at the cases that we presented to you, 10:01, 10:02 p.m., 10:03, the differences might rather be trivial, no, and but very arbitrary. Possibly, it was just a matter of one being able to reach out to for the phone or call out quickly. But then there's really no substantive difference between 01, 02, 03. There's no buzzer, there's no finish line, right? Or even if you can imagine somehow that doctors would be, looking for that buzzer, those who would be demanding for the attending physician. In a way, as you figured, there's no such thing, no. And in the actual situation, documentation of who comes first, who comes second, and so on, is rather blurry. They are all, hoarded up in a hall, and maybe it's a limitation. And even if you look at the community situation, those who are close to you, close to the hospital, are able to come, are able to show up in the hospital first, and so systematically disadvantaging those who live far, or those who have cars are able to come in early. So it's a terrible criterion to follow, first come first serve, and might not really be compatible with saving as many lives possible during crisis, because you may the first one who come up to you might have terrible prognosis, for instance, no. So that's one of the considerations there. Now, prognosis, of course, doctors would not want to pursue futile medical treatment. It's a waste of resources, and really magnified during crisis, because like the ventilator is very precious. It can potentially save more lives, and if you're stuck with a terrible prognosis and you keep on insisting on saving that person, you are essentially wasting valuable resources. Now, there are technical considerations that pulmonologists use, SOFA score, and I will discuss that in a bit. I cannot pretend that I know this and down to the technical details. I will just breeze through the key features relevant to our discussion tonight. But even SOFA score, and maybe though if there's any pulmonologists in the audience or among the participants, maybe Apache 2, more elaborate technical scoring on likelihood of survival. You will have to contend with probabilities, and the difference between, say, 50%, 51% may not really be that important, and so you're left with something arbitrary still, no. So take a look at this scoring. As I said, I'm not a pulmonologist, so I will not be able to tease out the very details of this, but the idea is that you have sequences of sepsis, of failures, and so somehow they're predictive of certain outcomes, especially death, no. So you have scoring under your right, maximum SOFA score all the way up to 24, and that would be greater than 90%. And there could be gray areas there, because 90% say would, and if someone comes with, say, 91%, is 1% really that important, or that a difference maker, no? So this consideration. So even with your technical basis, you may have to contend with the arbitrariness of making the cut, so to speak. So the choice of the person in charge, person deciding for you guys, would be in the situation we call moral distress. The attending physician has fiduciary responsibility to care. But at the same time, he knows, he's aware that he's in a crisis or she's in a crisis, and there's really an obligation to share. More specifically to ration, no? We're rationing scarce resources. So it cannot just be given on someone arbitrarily because it's your friend, no, just because he came first, no. So these are the considerations, and so he's going to experience torment. It's a natural consequence of your doctor being left alone to decide. And so spontaneous decisions on the spot, especially in crisis situations where you are already you have fatigue, you experience fatigue, you're missing you're missing food, you lack sleep, outcomes cannot be all good. And there could also be legal or ethical questions, no? And we'll see where that might, and who knows what the complications might be as a result, no? Another value consideration, normative consideration would, of course, be patient autonomy and patient's choice. As you can see, patient C made an advance directive, no, saying that I should not be intubated, I should not be put in a ventilator. But his wife said, no, that cannot be done. I mean, I am deciding now, no, I will override that. Now, is that ethically, legally valid? Legally, there are questions in the Philippines, especially because we have no advance directive framework. But in if you go by medical ethics, you might want to uphold the decision of the patient himself. No? So this is an important consideration. And so if we take a look at our guidelines, the guidelines I shared with you earlier, you'll see that we kind of raise some eyebrows because they say that Filipino culture is not receptive to advance directives. So families would go through the motions of really having to care, although belatedly, for someone, and say, oh, save him or whatever it costs. But precisely that's no longer possible because you're in a crisis, and it may not be fair for others if the treatment is futile, no? So I think the last question should be a difference maker. Clinicians, attending physicians should ask these questions for themselves, no? And ask the question to the in relation to the case. Now, did the patient consent to be put on a ventilator? That is an important question that I think many clinicians would rather ignore and assume that the patient would want to be ventilated, which is actually quite a jump, quite a leap. Now, if you take a look at this normative value, patient autonomy, personal choice, you cannot forget that question. All right. The next value argument would have to do with so-called fair innings. And the idea is that we all have we should all have a good chance of living a full life, normal life. And that is statistically predetermined. What is the life expectancy? Maybe Philippines would be about 70, 77. But as you can see in patient, with patient A and C, there are advanced age, no? And if you conscious that with Italy at the first peak, about March, April 2020, they came to stop treating 60 above. Think for a moment what that might entail in the Philippines. Imagine if you show up in PGH and you're 61 and you had India or Italy situation, and if the doctors would put forth this kind of argument or of this kind of value, so you have no way of being treated. All right. Now, that kind of argument might be vulnerable to some charges of ageism. We are discriminating against old people. That's one side. The other side has to do with age itself as a proxy, for comorbidities. Now, age, old people are not necessarily sick or don't have a lower chance of survival simply because they're old. But then there's this argument that they're really just vulnerable due to their comorbidities, hypertension, for instance, or some heart disease, no? And their chances of survival will be low because of comorbidities, not because they are old. Now, what do we have here now? So one way of looking at age is a proxy, no, as a proxy. It's a rapid assessment. In a crisis situation, you can't have people, check out for comorbidities. You can ask, and then people might not always be truthful, or might understate their comorbidity or overstate their comorbidity depending on the situation. And for most part, maybe such kind of assessment using age as proxy is rather inaccurate, nonetheless important. As a society, we decide that, hey, age is important. Look at your age of consent. No, when can you buy liquor? No, that's your legal age. When can you acquire properties? When can you get married? No, and so on. That arbitrary number, say 18, has far-reaching consequences, even if the idea of being able to decide is really very valuable. No, some of your siblings may be already 30 years old, but they still cannot decide for themselves. No, so they should not be given that age of consent, no, at 18, because obviously they make bad choices. No? Now, the other consideration is aging as a disease. So what do you think of that? It's going to be very controversial, but imagine if aging itself is a disease. That is an important screener, don't you think, in a crisis situation? And it's not my idea. I'm not also going to engage you guys if you're going to debate with me on the finer points of this claim. I will just direct to you this article, and there are people out there who are thinking that up to a certain point, if we are able to determine, maybe 150 should be our age, given the advanced medicine, the state of medicine, and nutrition, and so on. To die at 60 would be a sin, would be unthinkable. No, and so you are aging prematurely, so to speak. You should be reaching a certain age. No, so age, as again, this argument would maintain, is a good differentiator, a screener. No, now the last principle we'll be discussing tonight has to do with fair process versus fair outcomes. Now, hear me out on the difference between the two, right? In COVID crisis situation, you cannot always guarantee fair outcome, all right? So the greater chance of survival, they will in fact survive. You cannot guarantee that, no? But at the very least, your institution should guarantee fair process, being giving people equal chance of survival, and or chance rather, to avail of a system with rules that are really transparent. And so in the guidelines, we're proposing a triage team. We call it the Patient Liaison Committee. I'm partly allergic to committees because of the negative connotation it might entail, in some places anyway, meeting endlessly. But then it can be part of a proactive management of competing interests. And these competing interests are not always articulated in a crisis situation. So there's an argument to be made that we should be doubling down on our being self-conscious and being self-aware of the biases we might bring into the floor of the hospital. And it's a good measure to mitigate against moral distress. So remember all the responsibility, the torment you have assigned to that, physician in charge might be mitigated by this triage team. So who makes the final decision in prioritizing use of life-saving intervention? As predicted, you guys have chosen physician in charge. Which is not bad at all in a non-crisis situation. But I would say it's a terrible choice in a crisis situation. You're just putting too much burden on the shoulders of this physician in charge. All right, so that physician in charge will have to make rationing decisions. But he has to separate his responsibility for making rationing decisions from his clinical responsibility. Hard to do, especially if you are on the floor, or you're in charge of a ward or an ICU. You will have to just the same think of rationing decisions, but communication is key here, no? That you will be able to communicate the rules, no? The procedure, the decision process that you have to use when you make rationing decisions, no? There are pros and cons, of course. Triage committee versus your superhero on the right side, no? There are pros and cons, but at the end of the day, you may really have to consider closely having this triage committee. You may call it committee, you may call it team. In our case, we wanted to call it patient liaison committee because patients and their families have to be engaged in every step of the process. Once they get into the hospital, there's this magical thinking somehow in many cases. I can see that once they get into the hospital, thank goodness I'm in a hospital, I will be saved. There's no such guarantee in a crisis situation. And so fair process demands that you will be engaged at every step of the way. That may be laborious, but it need not be inefficient, all right, and a black box, so to speak, no? So when you enter a hospital, you come in fully aware that you could die anytime soon because there's only one ventilator left and you will be needing that ventilator in a matter of minutes, something that you don't have access to. All right, and so these guidelines we have, by the way, thanks to PCHRD for funding this. I see some colleagues from PCHRD. I guess your money is well spent. In crisis situation, you will have to look at allocation implementation. And this is not something that you would want to just delegate to a single, attending physician or attending physicians without coordination, because it's just going to be terrible waste of resources. Communication with family is undervalued, but it's really when you guys put it out there that, they can make prior preferences. No, advance directive is one, no? And you see people dying peacefully even in the crisis situation, and they would prefer that as opposed to being intubated and not really knowing your chances. No? Selection of criteria for ICU admission. ICU also, there's another layer there. Allocation of ventilator for use. Objective clinical parameters. You can still use SOFA, of course, no? But then you cannot just rely on SOFA because with experience, you see that it's not discriminant enough. Consistency and transparency cannot be overemphasized, and you keep on reassessing that. It's part of the crisis situation that cases are fluid. No, at one point you have a good chance, no, and even with the high SOFA score, they could still graduate into release. No, they could still be saved. No, I'm not suggesting that they are doomed. No, just because some statistics tell us that they're likely to die. They could still survive, but then in crisis situation, you will have to make hard choices, no, just so you can save as many lives as possible. So that ends my discussion for tonight. We'll see if you have. I'm sorry I wasn't able to respond to this in time. Dr. Marcelo is asking question. COVID positive husband patient declines intubation, and when becomes unconscious, wife via phone authorizes ventilation. How should the healthcare provider manages this? You will have to. There's no hard and fast answers. In the Western world, I understand. We have a UK case, for instance, where an advanced directive was overridden by family, and then the hospital was sued by the state for doing that. No, we don't have that kind of situation in the Philippines, and I say that our bias would still be towards the respect of that advanced directive. But then we will have to communicate with family because supposedly the Philippines would be more family oriented than UK. That's the assumption in a way. And of course, the triage committee will help you funnel through that. I mean, yeah, to vet the advance directive, because the advance directive might not be genuine. The family might have some competing interest in the death of that person, no, however young, no. Next question. 83-year-old stage renal disease, was advised transplant. Are the rules different if the donor is a relative or cadaver? That will be a different situation, depending on how urgent this is. They have, hospitals and even families are opting to postpone surgeries if this is really life-threatening, and renal, this is life-threatening, as I can understand. But we'll see how this might really be a a case that competes with life-saving resources. For instance, certainly he would probably be needing intubation in a way at some point, so that is also a consideration. There's a real case. Cop and robber shoot each other. This is life's jokes on people. Cop and robber shoot each other, but cop had worse prognosis. Should have the surgeon manage prioritization in single operations theater setup. The consensus among bioethicists, at least local ones, would say this is still a toss up, no, because you will have another layer of justice system to decide who's guilty or not. More than meets the eye, right? More than meets the eye. So robber, it depends on really calling robber and cop. In the Philippines, cops are the robbers, so, or could be the robbers rather. So it could be a toss up just the same. So as a clinician, you wouldn't want to deep into this kind of quagmire. No? So what's the role of DNR in the Philippines? That is an important question that we want really to highlight, and that's why my talk emphasize the importance of asking consent. But I think the problem is really more on the side clinicians assuming that the patient would want to be intubated. So I think that's the problem. But the hope is with patient advocacy groups. They are advocating for more and more respect for DNR. Yes, DNRs do not resuscitate. All right. So if there are no more questions,
Dr. Peter.
Yes, please, Dr. Eloy.
Thank you, Dr. Peter, for your time. I have one question. There's there's the new field of artificial intelligence and augmented reality that are now being applied in healthcare to assist doctors in diagnosis and sometimes to help patients um, have different perceptions of their environment. So it varies. It either impacts the decision making of the health provider or alters the perception of the patient for something in quotation mark for their benefit. Doctors are not trained on information technology. What would your suggestion be? I mean, I know this is a problem globally. How should the clinician judge or balance technologies like AI and augmented reality being introduced into their practice? What's your advice?
I'm not sure I have a good handle of how much AI, augmented reality, can we really bring into the picture, especially in terms of COVID. But I would say information systems in general and decision support, whether it's AI or augmented reality, should be brought in as early as possible. I think we have a problem of addressing fundamentals. I think even our contact tracing is really terrible. If you are able to bring all sorts of information before the actual contact in a ICU, that would be better. You can have big data, drive certain characterization or profiling in with your patients and their families. Uh, you have a pushback maybe from privacy people, but I would say handled well, that should really be brought in as early as possible, because it can really save lives, no? And just having a good inventory system that might be needed to address situations of pandemic, then you can somehow instruct your information system to help you decide um, which patient to care for, no? And that would be free of bias, no? And you can already input the algorithm, the decision procedures. And this is, I think the problem is really in the readiness of the consciousness, in the consciousness of people to accommodate these things. Hands down, machines, algorithms are better at making diagnosis, making decisions. But then we have clinicians who insist that, they are just machines, and they should really just support us. If I decide to treat this patient, machine, please support, find all sorts of excuses that I will treat this person, no? Because after all, I'm the captain of the ship. So I think the thinking has to shift first, and the requisite infrastructure has to be dovetailed with that. But I agree that there's certainly potential. There's so much promise, but that there's also threat. I can see, because maybe some people could manipulate the information system for certain yeah, all right, for certain
I'd like to share. I'd like
yes.
to share one session, coffee session I had with an oncologist. So they're experts in cancer treatment, and I told him about this. I won't name the brand, and I won't name the artificial intelligence system, but it helps in diagnosis and treatment of cancer patients. And he told me, he didn't really say, he didn't put down the system, but he said, if I disagreed with the AI and the patient went wrong, or the patient takes a downturn, then I will look bad because the AI actually said do A, but I decided to do B. But if I am better than the AI because I chose another treatment not recommended by the AI. Sorry, if I followed the AI and the patient died anyway, does that mean that I will be protected because I followed the algorithm proposed by the AI? And we were just thinking about, will there be a future where clinicians will then, in quotation marks, succumb to the or be subdued by the artificial intelligence is able to analyze much more evidence and heaps of data than a human person can. And there might come a future where the clinician might have to explain himself or herself if he or she decides not to follow the algorithm. you know so we didn't arrive at any proper resolution of that discussion, except that that opened up a lot of um, insights about the forthcoming influence of data in the practice. I wonder if there are other people in the audience who might have questions. I see Dr. Chamika from Sri Lanka. Maybe he has some questions, not to put pressure on him. DNR is do not resuscitate. And I think this is always, I mean, even in the Philippine General Hospital, um, this is a very uh, sensitive type of order that some doctors refuse to write down by themselves. They want something written down by either the patient, if that's possible, or by the guardian or the relative of the patient, because this is basically like hanging up your gloves on the patient and telling them, okay, this is the end for you, and for many clinicians, it's like losing the battle, and sometimes they feel bad about that. So I don't know if there are other clinicians in the audience who might want to share their experience. Dr. Chamika, could you like
Hi, can you hear me?
explain? Yeah,
Thank you.
yeah. Please go ahead.
And thank you, Professor Peter. That was an excellent presentation, and it was very insightful. So I was wondering because even in Sri Lanka, I mean, there's no place for DNRs because still the legislations and legal framework has not been implemented, and people are not aware about such. But there are certain, I mean, use cases in, I think, out of Asia, which I have read about, where the patient has already signed a DNR, but with the best interest of the patient and the probably the pressure by their relatives, the physician, they have resuscitated, and after the recovery, the patient he was disappointed because he had signed a DNR. Then he sued the hospital. There are certain incidents like that which I have read. So, I mean, it's something I think we'll have to maybe in near future, probably as Dr. Alvin said, probably AI driven and with the health information systems and all these things. I mean, which we will have to incorporate as well, and especially when it comes to health insurance and costing of those things also, I think those are also linked with the ethical standards or ethical considerations of the enrolled like that. Thank you so much.
Thank you for that, Dr. Chamika. I should look for that case in Sri Lanka. Interesting one, right?
Sorry, it's not Sri Lanka. It was in out of Asia actually.
I see. Okay.
Yes, not Sri Lanka.
Thank you.
Okay, any more queries? If none, thank you very much, Doc Peter.
Thank
Very
you.
very interesting presentation. I was hoping, I think we're recording this, but we'll show it first to you if you think it's okay to be put on our YouTube channel.
All right.
Thank you. Thank you,
Thank you.
everyone.
Thank you.
Good night. Thank you, Dr. Peter.
Thank you.
Bye-bye.
Good night. Bye-bye.